Geriatric Psychiatry, University of Toronto, is going to present on the overview of the normal sleep and various sleep disorders. So please welcome.
So, good morning. First of all, it's quite hard for me to switch gears from such a presentation by Dr. Buddha going to hardcore medicine, and on top, it's on sleep medicine. So, I feel the objectives of this presentation have changed. I think you should have peaceful sleep. That is how to get a peaceful sleep after the presentation. So we have 20 minutes. So when Dr. Larry approached me about sleep, I thought that it's quite a short time to cover the sleep medicine. So the purpose of today is what is normal sleep and what is abnormal sleep, and broadly looking at various diagnoses and what conditions we have. We won't go in detail. So when we talk, so there's no disclaimer. When we talk about normal sleep, if someone asks you, how many hours should I sleep? So, what would be the answer for by a physician or anyone? The answer is there are people who sleep 3 or 4 hours. They feel refreshed. They're productive, like probably Donald Trump, I guess. But there are people who sleep 10 or 11 hours, and that's probably normal for them. So there is no rhyme scheme. So the answer to the question is it does not matter. Whatever makes you feel more refreshed in the morning and whatever more productive. But there's normally human beings sleep about 7 or 8 hours. And it's evenly distributed, but it can vary. It's always spectrum. So sometimes we ask, hey, how tall a man should be to be good looking? And that's irrelevant question. Yes, if you're 6 foot, that's good. But if not, that doesn't mean that you're not good looking. So that's the analogy we give. How many hours you need to sleep? So typically, why do we sleep and who sleeps? Almost all human beings sleep, of course, all mammals sleep. If you see in this, you see that, for example, horses, killer whales, and cows, they sleep 4 or 5 hours, whereas human beings, they're in the middle. And another is, for example, bats and pythons and turtles, they sleep 18 or 19 hours. That's their normal. But all mammals sleep, and majority of the mammals, they have what we call bihemispheric sleep, which means that some mammals have half brain is sleeping, half is awake, so that they can save themselves from predators. But majority of the time, all the mammals shows unihemispheric sleep. Now, so when we talk about sleep, we have different EEG patterns. EEG patterns means that when you put your leads and you do EEG, you have different pattern about the sleep. And then majority of the mammals have the typical and characteristic EEG patterns. So sleep is a universal phenomena. So it is developed, and one of the reason for purpose of sleep is learning. Now, sleep is not that you become unconscious. Sleep is when you lose wakefulness. And in, I think, modern world, why we define sleep in a way that we need to reset. Same as we need to reset our computers, we need to reset our brain. Not only our brain, but also our muscles. So the sleep is designed that you reset your muscles at night and reset your brain. And if you reset all together, then your computer may crash. So you have to reset one at a time. And that's how we have, with the evolution, different stages of sleep has developed, which we're going to go around. So it's a shift in consciousness. If something need to be happen, you do wake up. You may wake up confused, but it's not that the lions are going to come and eat you when you're sleeping. So it's centrally involved in learning. There's a lot of research has been done. When you get up in the morning, the learning is more. Even when a good night's sleep is replicated to learning and attention, as well as limbic system psychopathology. So this is what I'm talking about. This is normal sleep. When we say normal sleep, we have two types of sleep. One is your brain is active and your muscles are paralyzed. Or second is when your muscles are active, your brain is paralyzed. Two types. So when we say your brain is active, your muscles are paralyzed, then brain is thinking. We have what we call, Freud said, day residue. We have everything, whatever is going on in life. can be reflected in your brain. If you are stressed during daytime, if you have something going on, it can be reflected in that sleep when your brain is active. And when your brain is active, your eyes needs to move as well. So because your eyes are moving quite a bit, so we call it rapid eye movement. And when rapid eye movement is happening, your muscles are resetting and they are paralyzed. And you need to be paralyzed when you're dreaming. And if somehow you lose that paralysis, your limbs are not in your control. And when your limbs are not in control, that is a pathology. You may end up hitting yourself, you may end up hitting your bed partners, and that's what we call REM behavioral disorder. That means that your muscles are supposed to be paralyzed in this stage of sleep, but it has not been paralyzed for various reasons, and hence this is a disease or this is an illness. So if you see in REM, this is a 25% of our sleep, approximately, uh, to 20 to 25%. It's REM sleep. And when you see the EEG pattern of this REM sleep, will go, your brain is fast. On the other hand, about 75% of our sleep is non-REM. What non-REM means is your muscles are working, you're tossing and turning, but your brain is resetting. So you're not dreaming. Your brain does not know what's happening. If I go and wake you up in that sleep when your brain is not working, you will wake up confused, and it will take few minutes for you to realize where you are. And there are a lot of psychopathologies that can happen. Now, this is 75% of the sleep. So hence we have divided this stage of sleep into three stages: N1, N2, and N3. Now, N3 is the deep sleep. Now, a lot of you start wearing Fitbits and probably, and end of the presentation would have questions how accurate they are, blah, blah, blah. But the answer is, if someone asks you, hey, why the hell I'm not getting the deep sleep, from my Fitbit, showing that I don't have deep sleep, that means I'm not feeling refreshed. But that's not the answer. Answer is the proportion of all the stages has to be accurate the way our normal is in order to have a refreshing sleep. If I only sedate you, hammer your brain, and give you 100% deep sleep, that may not be essentially more refreshing in the morning. So the normal sleep is two stages. We have dreaming sleep when your brain is working, and we have non-dreaming sleep when your muscles are working. So let's say if I put EEG on all of you, you're thinking your brain is waves are very fast, and we say these are the 15 to 30 hertz. These are beta waves. But then after this presentation, you're going to start feeling drowsy, for example, so that your brain waves are going to start getting slower and slower and slower. So when you're drowsy, it's going to be alpha, and then slowly theta, and then and then if you end up falling asleep, your brain is going to start slowing down until REM sleep hits. And when REM sleep hits, it's going to be more faster. So if you see the stage 3, which is N3 delta, it's 0.541 to 4 hertz. The waves are way too slow. So you're awake, waves are fast, you're slowing down. So awake, beta wave, third. So yes, you're slowing down. And then after some time, REM is going to kick, your brain waves are going to be faster again. And that's what the normal stage is. Now, this is what people have seen on Google. This is called hypnogram. So what essentially it is, you see this on one axis, you see wake, and second axis, you see the time. So you see the person went to bed at 2200, and then 2300, 24, and 123. And on top, you see the stages. This is a little bit older graph, like we used to call S1, S2, these N3. So if you see 10 o'clock, this person went to bed, and it took you at 10:30. It took person half an hour to fall asleep, and then he went to S2 stage, which is N2 stage, and then he went to S4 stage, which is N3 stage, deep sleep, and then it comes in cycles. So 90-minute cycles. So if with the evolution, for example, let's say if we have first half non-REM sleep, second half REM sleep, in REM sleep, we probably are in danger. And hence, it has to be rotating. And we don't know which cycle, which part of REM or non-REM you are in. So if you see slow wave sleep or most the non-REM sleep, it is in the early part of the sleep. But early morning, if you see, you're more REM sleep. REM sleep keep increasing with the day as your night progresses. And hence, when you get up in the morning, probably you wake up in a curled up position. And also, you wake up dreaming. And there are several physiological changes that can happen in your sleep when you get up in REM sleep as well. It is very hard for you. You can't get up in non-REM sleep. If I come and wake you up, let's say within 15, 20 minutes, you may get up confused. So as the night progresses, you see around 6 o'clock, 7 o'clock, there's more REM sleep. And that's why we all have more dreams in the morning and we are able to remember. Now, dreams can be bad. If dreams are bad, if someone has trauma or someone has witnessed something, the dreams are becoming more disturbing and you're waking up with the dreams, but you're not confused. The dreams are bad. They are not pleasant dreams. They are not happy dreams. They are not dreams that you want. And that may be repetitive dream. We say that these are bad, bad dreams, and those are called nightmare disorders. And hence, you get nightmares in the second half of the night, which is during REM sleep. Because your dreams, you're supposed to dream, your brain is active, but because of your circumstances, you're having more bad dreams, which are nightmares. But you must have seen in movies, you wake up confused, sweating, and screaming and yelling. You don't know what happened. And you wake up suddenly. And you have all the autonomic symptoms going on, not with nightmares. Nightmares, you wake up confused. You tell the people, you tell your doctors, hey, man, I'm getting this, I'm getting this many repeated dreams for my blah, blah, blah. But not with the other one, where you wake up screaming and this is really, really, you have sweating, you have heart rate, blah, 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 pounding, all those things. Those are not in your dreaming sleep. Those are in your non-dreaming sleep that is waking you up confused. And those are not nightmares. We call them sleep terrors. So those are different. Now, if in REM sleep, we should be paralyzed, but we lost our paralysis and we start hitting people, we call REM behavioral disorder, which is more common with Parkinsonism and everything. But what happens when in non-dreaming, your muscles is active in bed, you should be tossing and turning, but it is not active. It's literally taking you somewhere else. And you start wandering around. And that is called sleepwalking or somnambulism. So that is non-REM, if that makes sense to you, because it's not paralyzed and you don't know. And if I wake you, if I'm doing sleepwalking, I wake you up, you will wake up confused and you won't even realize where you are. And you will see this psychopathology does not end there. That's why in psychiatry, if we follow DSM, it comes with sleepwalking with or without. And then we have other problems. A lot of people you will see in this sleepwalking, they go to the kitchen, they start eating without realizing. And when they come, and this is a big problem, and it's not that uncommon if that makes you, if that makes you like you haven't heard about it. This is way too common to the point that in our world, it's one of the cause of obesity. Non-REM, because of the time constraint, I won't go in detail, but when you're doing non-REM, which means that you're not dreaming, your muscles are active, your brain is not working, and when your brain is not working, you're going to do a lot of criminal activities as well. And hence, you drive in sleep without realizing, and hence these are real patients, had fist fight with police officers, stab police officers, stab here, having sex, which is called sexomania. So without realizing, you're going out and doing complex motor activities. And that is also called parasomnias, non-REM parasomnias. So if we talk about REM parasomnia, param is beside, this is not normal. We have nightmares, REM, of course, REM behavioral disorder, but when it comes to non-REM, there is a lot of problems, rare and common. And most common, that is sleepwalking as well, and night terrors or sleep terrors. So if someone asks you, hey, I have a problem, it's very important for us to know what half of the night this problem starts. So based on that, we know whether the pathology is in REM or non-REM. So normal sleep. Now question is, hey, I'm 60-year-old or I'm 30-year-old. Hey, I'm not sleeping that much. Is this because I'm old? No, your quality of sleep is not going to go down. Yes, your deep sleep is going to go down and your cycle may shift, but your need still is there. And when we say need, we need physiological need that helps your cardiovascular system. If there is a problem that your muscles used to be strong, now they are not strong anymore, they are floppy, they don't respond, your reaction time has decreased, so it's your muscles. On top, you have gained weight, and on top, you don't even care about anything. And you are 60, 70-year old, you go to bed, you're against the gravity, your cavity is going to close, muscles are not strong enough, you're going to stop breathing. It does not matter because you're a strong man, you're going to stop breathing several times in the middle of night. And you will be surprised how many people stop breathing more than 30 times in an hour, which is every 2 minutes. And that's what we call severe obstructive sleep apnea, if that makes sense. So now we all feel drowsy and sleepy during the daytime, noontime. That's normal physiology. When we talk about insomnia, we talk about sleep debt. Sleep debt is that if I get up at 5 o'clock in the morning, I will be tired by 8 o'clock because I've accumulated so much sleep debt. But this is normal. This is how sleep debt is being accumulated. But then we have to pay a little bit debt in the afternoon. So that's normal physiology. If if you feel drowsy or sleepy during after lunch, and there is something called postprandial drowsiness, which means this. Okay, we all feel this is normal physiology. In the evening, sorry, in the afternoon after lunch, I'm feeling sleepy. That's normal. But how about if it's abnormal? And to the point, you will see people literally eat and sleep. They eat burger while driving and literally they crash car. And that's called postprandial drowsiness. And that's also a pathology. You have to treat with Ritalin or all stimulant medications. That's that big of a problem. So just to know that these are normal physiologies, those are pathologies. So
Yes, you have for three.
okay, so I won't go in this. So what I just want to know, I mention how do you measure your sleep? Three things I want to mention. One is called sleep efficiency. So this word, if you Google what sleep efficiency is the hallmark of treating insomnia. Now, sleep efficiency is number of hours sleeping divided by number of hours in bed multiply 100. So if someone has insomnia and if you sleep 5 hours and you're in bed 10 hours thinking you are going to catch up your sleep, multiply 100, that is 50% sleep efficiency. Now, in order to make this sleep efficiency 100%, either I make the equation 10 divided by 10, which means I hammer your brain, I sedate you with benzos, alcohol, whatever you want, and that make it 10 divided by 10. That is how I can improve your sleep, but that's against the nature. But if you want the natural, we call it what we call sleep restriction therapy. And what it is, you make the equation 5 divided by 5 multiply 10. That means you do opposite to what your brain is telling. So you stay in bed only 5 hours and you restrict your sleep. So you don't go to bed, you don't fall asleep, you don't sleep, you sleep only 5 hours so that we can make equation 5 divided by 5. Last thing is how do we measure sleep? Now we do tests. Most common sleep problem is obstructive sleep apnea. So what we do is we do sleep diary to rule out if you have insomnia or not. Then we have what we call polysomnography study, which is overnight sleep study. So we put all sorts of leads like this. We have all sorts of channels, and what it tells us is whether how many times you've stopped breathing at night. So based on that, we diagnose you obstructive sleep apnea. Now, the other illness is you sleep too much, which is called hypersomnia. And one of the hypersomnia commonly you must have heard is narcolepsy. So narcolepsy is when you get sleep attacks, and when you laugh or joke, you get paralyzed for a moment. And then when you go to bed, your REM starts kicking in and you start hallucinating. And when you get up, you start hallucinating as well. And we do what we call multiple sleep latency test. So this is the last slide I'll show you. These are the things I was talking about. We have insomnia disorder. When you don't sleep, you have initial insomnia, maintenance insomnia, which is called middle insomnia, or terminal insomnia. You have hypersomnia, which means either you have narcolepsy or you're sleeping too much for some reason, and we can investigate that. Then you have breathing-related sleep disorder. You have obstruction, you have obstructive sleep apnea, or your brain starting to stop working because you're on you're on benzos or opiates or methadone, and hence the brain is not stimulating your lungs to produce breathing, and hence that's called central sleep apnea. Or if you're obese, this is obesity hyperventilation syndrome. And then we have circadian rhythm sleep disorder, which is for most of the teenagers suffer as well. And then we have sleepwalking, sleep terror, we went over, REM behavior disorder. And one thing, last thing, which I will cover is called restless leg syndrome or periodic limb movement disorder. This is also sleep medicine. That means you get this uncomfortable feeling that you need to move your legs in order to feel better. Typically, most commonly we do is we do iron level also. So we have to check low ferritin pregnancy, for example. If people are on dialysis, that could be, and we have the treatments accordingly as well. When people have restless leg syndrome, in the night also they have restless leg syndrome and they move a lot, kick a lot, and that disturbs your sleep. And we can find that through overnight polysomnography study as well. So I think I'll end it. Thank you so much for this. This was just a brief overview.
Thank